Well, thank you. That's a great introduction. It is a privilege to be part of the Aspetar team for 3 months, and I'm really honored to give a talk this morning. And this is the cover of my PhD thesis, and as the title might suggest already, the talk of today will be on hip morphology and the relationship with osteoarthritis and the development of hip morphology in young athletes. For the ones who are interested in this subject, you can download my full thesis in app. Just download the Your Thesis app in Google Play or the App Store, and you will find my thesis in the library. Otherwise, you can also just send me an email and I will provide you with a PDF of my thesis. But let's start. There's an athlete, 20 years of age, asymptomatic, only limited internal rotation, and his hip looks like this. Intraoperatively, it looks like this. And for the ones who are not familiar with radiographs of the hip, here is the femoral head. This is the acetabulum. And the femoral head is supposed to be spherical. And you clearly see here that there's an extra bone formation, and here during the operation. So what would you do in this case? Would you do nothing? Would you provide treatment, either conservatively or surgically even? To give answers on these questions, I will first explain a bit what is femoroacetabular impingement, or FAI. So this is rather a bit of a theoretical definition, but there are 4 important issues in this definitions, 4 important elements. So FAI is a clinical entity which causes hip pain. So in the previous case, there was no hip pain. The athlete was asymptomatic. So based on this definition, there was no FAI basically. When there's hip pain with morphological abnormalities, and those can be located on either the acetabular side or the femoral side, combined with vigorous hip motion, that's the 3rd important part, should be vigorous hip motion, that lead to repetitive collisions of the bony morphology within the hip joint, and that might damage the soft tissues within the hip joint. And we came up with this definition in a consensus meeting 2 years ago. But as this is a rather theoretical definition, I will show you some more examples with some figures. So the morphological abnormalities can be located either on the acetabular side or the femoral side. When it's located on the acetabular side, like here, we call it the pincer deformity. And when the abnormality is located on the femoral side, we call it a cam deformity. And what is the mechanism by which a pincer deformity might lead to intra-articular hip damage? Well, the pincer deformity is basically an overcoverage relative to the femoral head, mostly located on the anterior side of the acetabulum, which means that during hip flexion, the femoral neck can abut against the acetabular rim. And because of the leverage effect here, the femoral head might slightly subluxate and also cause damage in the posterior part of the acetabulum. And the proposed mechanism states that cartilage damage might occur within the whole hip joint. But recent studies are a bit inconclusive, basically, on whether a pincer deformity is really a pathology. In a prospective study in the large cohort we did, we couldn't find any association between the presence of a pincer deformity and development of osteoarthritis. So then cam impingement. I will show you the mechanism of cam impingement by this clip. Here's the proximal femur. There's the cam deformity, the extra bone formation, It's mostly located in the anterolateral part of the femoral head-neck junction. And during hip motion, and because of the location of the cam deformity, mostly during flexion, together with internal rotation, there might be an impingement between the cam deformity within the acetabulum. And when this impingement occurs repetitively, there might be acetabular cartilage damage and damage of the acetabular labrum. And when this process goes on, there might eventually develop osteoarthritis of the hip joint. But a cam deformity is not straightforward to quantify. It is the extra bone formation, and we can see that on radiographs or on MRI. But if you really want to quantify it, it's not that straightforward. And that's nicely illustrated by this study. What they did is had just a bunch of radiographs of symptomatic people with FAI. And they asked 3 orthopedic surgeons to quantify them with different kinds of measures in whether they had or had not a cam deformity. And the agreement between the surgeons, it was not bad, but it was definitely not good. And they did the same for radiologists, about the same results. It was not bad, but it was not good either. And here comes the funny thing. When they compared the orthopedic surgeons with the radiologists, it was really a bad agreement between hips that were defined as having a cam deformity or not. So we need quantitative ways to define the presence of cam deformity. And the measure nowadays most often used is the alpha angle. I won't advocate that this is the best measure, but it's the measure mostly used, and I will use it throughout my presentation. That's why I will show you how it is measured. On the left side, you see a proximal femur with a spherical femoral head. The alpha angle is drawn by first fitting a best fitting circle around the femoral head. Then a line is drawn from the center of the head through the center of the femoral neck. And then a second line is drawn from the center of the femoral head through that point where the bone first departs from the circle. And in a spherical femoral head, the alpha angle is usually low. And here on the right side, in a hip with an aspherical femoral head with a cam deformity, the alpha angle becomes higher. So the bigger the cam deformity, more or less the bigger the alpha angle. And we define the presence of a cam deformity by an alpha angle higher than 60 degrees. But is it actually related to pathology? Yes, it might be. This is only one prospective study available in literature. They studied 170 asymptomatic subjects with a mean age of 30 years. And so they were all asymptomatic at baseline, and they followed them up for 4.5 years. And those with a cam deformity were 4.5 times more likely to develop hip pain as compared with those without cam deformity. But it is important to mention here that only 20% of the people with cam deformity developed hip pain. And Andrea got very recently a systematic review published on factors that can differentiate between people with and without OA, also radiographic features, and she could only include one study where they studied the same question in athletes, and only that study also did show an association between a cam deformity and hip pain. And further, cam deformity is associated with limited range of motion. That's quite consistent in a bunch of articles in which they show both in symptomatic and in asymptomatic subjects a relation between having a cam deformity and a limited internal range of motion. And this is an interesting study which shows that cartilage damage due to a cam deformity can already develop at a very, very young age. This is a Swiss study with 244 army recruits with a mean age of 20 years. And 67 of them had a cam deformity, which is a quite normal prevalence. You would see it in about 25% of the general population, at least in males. And they found out, what is shown here by this figure, that the straight line are the hips with cam deformity, and the dotted line are the hips without cam deformity, and this line is shifted towards the left, which is the cartilage thickness. And the hips with cam deformity had on average a 0.2 millimeter less cartilage thickness when the acetabular and femoral cartilage layer were combined. And there's also a correlation between the size of a cam deformity and the cartilage quality. So the bigger the cam deformity, the worse the cartilage quality. And this is nicely shown by a study using degemerate. I won't go into detail of this imaging technique, but it's basically an MRI-based technique in which you can visualize the cartilage and it will say something about the quality of the cartilage. So on the left side, you will see a hip of a normal hip without cam deformity. So this is the femoral head, again, and here's the acetabulum. And the more green the color, more green, blue the color, the better the cartilage. So basically in a normal hip, there's normal cartilage of normal quality. And here in the hip with cam deformity, you see more reddish color, which means bad cartilage quality. And also here, more reddish color, especially on the acetabular side. So it's most often the anterolateral, the anterosuperior location in the acetabulum. And we can also see that during surgery. This is a picture of an arthroscopy in which you see here the acetabular rim with the labrum. And this is basically the acetabulum. And here is the cartilage and the subchondral bone. So in normal situation, the subchondral bone would be covered by the cartilage layer. But because of the cam deformity that impinges in the acetabulum, the cartilage layer is completely separated from the subchondral bone. And we see this really damaged hip joints already in very young athletes. But will it lead to OA? Another important question. We did a study in a large cohort of 1,000 Dutch subjects with a mean age, somewhat older people, mean age of 55 years. And on the x-axis, there's the alpha angle, so the measure of cam deformity, and on the y-axis, the degrees of internal rotation. And every green dot represents one hip. So there are about 2,000 hips in this figure, and that were all hips at baseline. We followed them up prospectively for 5 years, and it's important to know that at baseline, they didn't have definite signs of radiographic OA yet. And the red hips here in this figure are the hips that went on to a total hip replacement within 5 years, so very fast. And if we then look at baseline at the hips that had a cam deformity, so an alpha angle higher than 60 degrees, we found a 4 times higher risk, about 4 times higher risk of developing end-stage OA. But it's also important to mention that a lot of green dots are still in here. So a lot of people with cam deformity don't develop OA within 5 years. And also we found that the larger the cam deformity, the higher the risk of developing osteoarthritis, with an odds ratio of almost 10. And when we combined the internal rotation and the alpha angle, so these are the people that have a big cam deformity together with decreased internal rotation. If we have that combination, it increased the prediction of getting OA significantly. with a positive predictive value of 53%, whereas the a priori chance of getting OA in this cohort at baseline was only 2%. So yes, cam deformity is also associated with hip osteoarthritis. So again, this case, this asymptomatic 20-year-old soccer player, what would you do? Knowing this, would you go on to surgery? People do preventive surgery on asymptomatic people. And it's not my opinion is that I completely disagree with that, but it happens. And we got really often the question, what should we do with these patients, these asymptomatic patients, limited internal rotation, not yet pain, because we know once they develop pain, they can go on and really rapidly progress having severe cartilage damage. But shouldn't we do a step back? Can we do better? Shouldn't we look at how a cam deformity develops in the first place? So that's the second part of my talk. Because there's quite a bunch of literature suggesting that the prevalence of cam deformity is much higher in the athletic population as compared to the non-athletic population. So there are studies in adult athletes showing a prevalence of 60 to 90% of cam deformities, which is really high. And also, we did a study, and there's other literature on this, which compared directly athletes with non-athletes and showed a big difference in prevalence. So the difference in prevalence can be as high as 90% in the athletes versus only 10% in non-athletes. And this is actually quite interesting finding, because this means that a cam deformity can possibly be prevented. So before we can introduce like preventive strategies, we have to know better when a cam deformity develops, how it develops, if there's certain loading patterns that trigger the deformity, is there a certain amount of intensity of soccer practice that triggers the development. So we designed a study 5 years ago in which we studied youth soccer players in the age from 12 till 18 years. And 5 years ago, we didn't know what to expect. We basically first wanted to study participants from 9 until 18 years, but we didn't get ethical permission for that. So we studied athletes from 12 until 18 years. And the first question was just very simple. At what age do we first see a cam deformity? Or do we see them already in the 12 years old? And we actually noted that the cam deformity became radiographically first visible from the age of 13 years. And we followed them up for 2.5 years. We had radiographs again, and this was a cohort of 89 soccer players. We had radiographs again, and we found out that the size of a cam deformity from the age of 13 years on gradually increases in size. And another interesting finding was that people that have had a closed growth plate didn't develop any more a cam deformity. And also the cam deformity didn't become bigger after the growth plate was closed. So this highly suggests that the development of a cam deformity is a bone adaptation in response to athletic activities during skeletal growth. And so these are a few examples of our cohort. This is an AP radiograph, AP pelvic view of a 12-year-old guy who has a spherical femoral head, and 2 years later a little bit of bone formation has occurred here. You can see it better on the lateral views. You can see a nice spherical femoral head, and 2 years later, extra bone formation has occurred, and a flattening of the femoral head-neck junction is there. And also here, this was a 14-year-old guy at baseline, already has a flattening of the femoral head, and 2 years later, he developed more or less a prominence of the head-neck junction. And here again, on the lateral views. So the flattening and the bump here, 2 years later. So this is a little bit how it looks like in time. Soccer players start with a spherical femoral head, then gradually develop a flattening at around the age of 14 to 15 years, 13, 14, 15 years. And then at the age of about 16, 17 years, it might look like this, like a prominence. And after closure of the growth plate, the shape won't change anymore. And can bones adapt to mechanical loads? Well, yes, they can, and this is very nicely shown by the following clip. People who were at the groin conference might already have seen this clip, but it's really illustrative. And I will introduce the clip first, very briefly. When young children have bone tumors of, for example, their proximal femur, it's sometimes necessary to remove the complete femur, and then the proximal tibia is placed into the acetabulum. And that allows that people can have a prosthesis here with a quite normal, normal hip function, I wouldn't say, but they can function. And the clip I'm going to show is our radiographs immediately after this procedure, in which the proximal tibia is placed in the acetabulum, and radiographs after follow-up after this procedure, and they are morphed in the clip. So this looks like this. Here's the proximal tibia, just immediately after the procedure. You can, during follow-up, you can see that it changes, and the proximal femur, or the proximal tibia, looks like a femur here again. So, and bear in mind that this bone was genetically imprinted to become a tibia, and now the shape looks like a femur because of the mechanical load applied on it. And that's not only in the hip. There are two experts in the room, in the audience, which already showed that bones can adapt to the mechanical load, well, at least partly due to the mechanical load in other joints. So this is the case in shoulders, where baseball players have more humeral retrotorsion in the throwing arm, and also in the knees, where load-bearing sports, and especially soccer, has been associated with development of varus knees. And this is nicely shown by Rod and Eric. So why around the age of 12 years? Do we have explanations for that bones adapt in this specific time period? Well, this might be partly an explanation. At around the age of 12 to 13 years, and especially in boys, there's a second growth spurt. In females, it might be somewhat earlier. And during this time period, there's an increased level of growth hormone and IGF-1. And in this period, the bone might be most responsive to exercise, basically. So that might partly suggest why a cam deformity and other bone adaptations occur at this age. So there's the peak. And we also found a dose-response relationship between practicing soccer during the age of about 12 to 13 years and the development of a cam. So we did that in a retrospective study. We had 63 soccer players x-rayed. They all played in the highest league in the Netherlands. And we retrospectively asked them at what age they started to play football and at what age they started to play football at a high intensity. So all those 63 soccer players started to play soccer very early, but only around about 2 or 3 times a week. And at different ages during adolescence, they started to play for professional teams and they started to play more than 3 times a week. So in the boys who started only after the age of 12 years with more than 3 training or med sessions a week, they only had a prevalence of 40% of chem deformity. Whereas the soccer players that started playing soccer at a higher intensity before the age of 12 years, they had a prevalence significantly different of 64%. So this highly suggests a dose-response relationship between the two. And this was based on a chem deformity with an alpha angle higher than 60 degrees. And if we have a bigger chem deformity, we notice these differences as well. And this illustration is by Jan Lemeur. He makes great graphics of different kinds of studies. You can follow him on Twitter. I would really recommend that. And finally, can we say something about which loading patterns trigger the formation of chem deformity? We did a study on that. We made a model, an finite element model, which is basically a computer model in which the characteristics of the bone and the growth plate are entered in a model, and we applied all different kinds of loadings to that model. So loadings representing gait, internal rotation, external rotation, and flexion. And what we found out was that when we applied loads of external rotation and flexion, there's a trigger, especially during external rotation, of a bone stimulus here in the anterolateral part of the neck. And that's the part where normally a chem develops. And we also saw that a little bit less for flexion. Whereas for gait and internal rotation, the loads applied to the hip are absorbed by the growth plate and are spread throughout the bone. Whereas here it's focused only at this part. And when we look at the growth plate, we also notice that for external rotation, there was a high stimulus for bone formation in the anterolateral part during external rotation. So again, the part where chem deformity normally develops. So the take-home messages for my talk is that a chem deformity is associated with limited range of motion, with pain, and with osteoarthritis. But take in mind that the majority of athletes with a chem deformity radiographically only, the majority of them will remain asymptomatic. And the development of chem deformity is in most cases a result of vigorous hip loading during adolescence, and this might provide opportunities for prevention. So again, back to our 20-year-old asymptomatic soccer player. I would say now keep calm, but stay alert. When once he develops hip pain, which might be due to the chem deformity itself, he might already have quite advanced cartilage and or labral damage. So finally, future perspectives. Where should we go? Here in Aspetar, there are some great studies going on or about to start. The first one is the study by Andrea Mosler, a big prospective study with 2 years follow-up in the groin screening. And a very important question in that study will be, and that's really an important question because we don't know much about that in literature, which hips become symptomatic? Can we predict, based on clinical examination or based on other variables, which hips with chem deformity will become symptomatic? And the second study which is going to start here, is an absolutely great study. The development of hip abnormality study, or DOHA study, by Paul Dijkstra. And this is basically a prospective MRI study comparing adolescent athletes of different kinds of sports, and it will provide much more information on how a cam deformity develops and whether there might be maybe future preventative strategies. So I would thank you all for your attention, and I would thank also my colleagues of the Erasmus Medical Center who I did the research with. Thank you.